3 days ago, the World Health Organization made an announcement that only happens once every few years. They declared a public health emergency of international concern, the highest alert level they have. The 8th time in history they've ever done it. And then most people went about their day. The reason for that declaration is an Ebola outbreak that has spread across 2 countries, crossed an international border into Uganda's capital city, and prompted the first emergency medical evacuation of an infected patient to Europe in this outbreak. An American doctor airlifted to a high-security isolation unit in Berlin. As of this week, over 600 suspected cases and more than 139 deaths have been reported, and the numbers are climbing. But that is only part of the story. Because while Ebola is dominating the headlines that are bothering to cover this, Marburg, a virus from the same family, with a fatality rate that can reach 88% and with 0 licensed vaccines, has been running its own quiet campaign. Ethiopia, Tanzania, Rwanda last year. It keeps appearing. And the 2 diseases are close enough in their early presentation that they can be mistaken for each other. For malaria, for typhoid, for a particularly bad bout of flu. So today, we are going to go through both of these viruses, where they actually come from, exactly what they do to the body, and when, where the symptoms overlap, and where they split apart, and what is happening on the ground right now that every informed person should understand. This is not a video about panic. It is a video about knowing what you are actually looking at. Let's start with what these 2 viruses actually are, because understanding their biology changes how you understand everything that follows. Both Ebola and Marburg belong to the same viral family, Filoviridae, commonly called filoviruses. If you have ever seen an image of these viruses under an electron microscope, you would understand the name immediately. They look like long, thin threads, sometimes curved, sometimes looped back on themselves. Almost beautiful, if you didn't know what they were. At the structural level, they share a tremendous amount. Same shape, similar replication mechanisms, similar ways of dismantling the human immune response. They are, in the language of virology, cousins, related but not identical. The key biological difference starts with where they live when they are not infecting humans. Ebola, and specifically the Zaire strain and the Bundibugyo strain currently causing the outbreak in the DRC, primarily comes from fruit bats and, in some cases, other animals like chimpanzees and forest antelopes that have themselves been infected. The precise reservoir dynamics are still being studied. But what is clear is that humans typically make contact with the virus through infected animals or their environments. Marburg's primary natural host is far more precisely identified, Rusetus aegyptiacus, the Egyptian fruit bat. This specific bat species is often found in large colonies inside caves and old mines. The earliest known human cases of Marburg, the 1967 outbreaks in Germany and Serbia that gave the disease its name, came from workers handling infected African green monkeys. But the bats are the persistent reservoir. When Marburg appears in humans, the starting point is almost always some form of direct exposure to environments where these bats live. Caves, mine shafts, sometimes just proximity to large roosting populations. This is the first meaningful practical difference. Ebola's animal origins involve a broader cast of potential wildlife contacts. Marburg traces back, with uncommon regularity, to one specific bat species in one specific type of environment. Now, let's talk about what these viruses actually do when they enter a human body. And here we need to be specific, because the progression is where most of the fear and most of the clinical confusion happens. After exposure, both viruses go quiet. This is the incubation period. Typically 2 to 21 days for Ebola and 2 to 21 days for Marburg as well. During this window, you feel nothing. There is no warning. Then, with what clinicians frequently describe as startling abruptness, everything changes at once. The first phase of both diseases announces itself the same way: sudden, high fever, the kind that arrives without warning. A headache that most patients describe as severe and persistent. Muscle and joint pain throughout the body. Profound fatigue, not tiredness, but the kind of physical collapse where getting up from a floor feels genuinely impossible. Loss of appetite, malaise so complete that patients report feeling, in the words of one Marburg survivor, like something fundamental inside them had stopped working. Up to this point, you cannot tell the difference between Ebola, Marburg, malaria, or a severe influenza. You genuinely cannot. This is not a limitation of clinical knowledge. It is just what the early phase looks like. Every one of these diseases begins this way. A physician in an area seeing all of these would need testing to know which they were dealing with. Then, around day 3 to day 5, the diseases begin to separate. With Ebola, and this is one of the clinical details that experienced clinicians have used as a distinguishing marker, a rash appears. It's a maculopapular rash, meaning it presents as flat discolored areas and small raised bumps, primarily on the trunk of the body. It is not dramatic the way most people might picture a disease rash. It can be subtle, especially on darker skin, but it shows up. Alongside this, Ebola patients commonly develop pharyngitis, a sore, inflamed throat, and a distinctive symptom that has been noted repeatedly across Ebola case studies: hiccups. Persistent, uncontrollable hiccups that reflect irritation of the diaphragm and abdominal organs as the infection deepens. It is an unusual thing to list as a disease symptom, but it appears often enough in Ebola that experienced clinicians treat it as a flag. Gastrointestinal symptoms in Ebola are typically severe: vomiting, watery diarrhea, significant abdominal pain. Patients can lose enormous amounts of fluid and electrolytes rapidly through these symptoms, and the resulting dehydration and electrolyte imbalance, the sodium, potassium, and calcium crashes, contribute meaningfully to the deterioration that follows. Marburg, in contrast, tends to present with more pronounced eye involvement in the early to mid-phase. Conjunctivitis, red, inflamed eyes with notable discharge, appears more consistently in Marburg cases than in Ebola, and some clinicians have noted that Marburg patients in the severe phase can develop a particular appearance: sunken eyes, slack features, a profound blankness that observers in historical outbreaks described as ghost-like. This is not a clinical term, but it has appeared in enough independent accounts of Marburg patients to be notable. Both diseases will eventually move toward hemorrhagic symptoms if they progress to severe stages. The bleeding associated with viral hemorrhagic fevers is something that people tend to dramatically misrepresent. Popular culture suggests catastrophic, explosive bleeding from everywhere simultaneously. The clinical reality is different. Hemorrhagic symptoms typically present as small petechiae, tiny burst blood vessels under the skin, bruising that appears without impact, bleeding around intravenous sites, and mucous membranes, blood in vomit or stool. In the most severe and typically fatal cases, more significant bleeding does occur. But the image of someone melting from the inside is a dramatic distortion of what these diseases actually look like at the bedside. What kills people in both Ebola and Marburg is not primarily blood loss. It is multi-organ failure. The virus, and more precisely the immune system's overwhelming response to the virus, damages the liver, the kidneys, the vascular system. Blood pressure collapses. The heart is starved of oxygen. Coagulation goes wrong in both directions simultaneously, clotting where it shouldn't and failing to clot where it should. Patients go into shock. In fatal Marburg cases, death typically arrives between day 8 and day 9 after symptoms begin. Now the question of treatment and vaccines, because this is where the two diseases stand in very different places in 2026. Ebola, specifically the Zaire strain, has a licensed vaccine. It's called Ervebo. It was approved in 2019, developed with significant involvement from the NIH and other global health institutions, and it works. It has been deployed in outbreak response settings and has demonstrably helped contain the spread of Zaire Ebola. There is also a 2-dose vaccine regimen for additional protection. But here is what makes the current DRC outbreak particularly alarming from a treatment standpoint. The strain causing this outbreak is not Zaire Ebola. It is Bundibugyo virus, a different species within the Ebola genus. Ervebo does not cover it. There is no licensed vaccine for Bundibugyo. Experimental candidates exist, and clinical teams are working under emergency protocols. But as of right now, the standard protective tool that changed the calculus on Ebola response in 2019 is not available for this particular outbreak. Marburg has no licensed vaccine at all. Multiple candidates are in development and have shown promise in trials, but none have been fully licensed. In both diseases, the current standard of care for patients is supportive treatment, replacing fluids and electrolytes, managing blood pressure, maintaining oxygen levels, treating secondary infections. The medical goal is to keep the patient's body functional long enough for their immune system to build a response. And that approach does save lives. Marburg's fatality rate, which can reach 88% without care, falls considerably with early, high-quality supportive treatment. The difference between 88% and 24% in Marburg outcomes is not a different drug. It is the quality and timeliness of care. So why are both of these viruses appearing so frequently right now? Because if you look at the recent outbreak record, it has been relentless. Rwanda had a significant Marburg outbreak in late 2024, concentrated heavily in healthcare workers. Tanzania confirmed Marburg in January 2025. Ethiopia confirmed its first-ever Marburg outbreak in November 2025, with a 64% fatality rate among confirmed cases. Uganda had an Ebola outbreak caused by Sudan virus in early 2025. The DRC just declared its 17th Ebola outbreak since 1976, and the WHO elevated it to a global health emergency within days. The frequency is not coincidental. The structural drivers are well understood at this point. Population growth pushing human settlement deeper into previously undisturbed ecosystems. Increased proximity to the wildlife reservoirs, bats, primates, forest animals that carry these viruses. Mining activity that brings people into caves where Raucetus bat colonies live. Climate shifts that are altering the geographic ranges of reservoir species. Healthcare systems that remain underfunded and understaffed in the regions where these outbreaks consistently originate, which means cases go undetected longer, and by the time they are identified, chains of transmission are already established. The DRC situation adds another layer of complexity that makes this outbreak particularly difficult to contain: active armed conflict. Insecurity in Ituri province means health teams cannot always safely reach affected communities. Population displacement creates movement patterns that health authorities cannot track. Mining-related population flows across the Ugandan border create exactly the kind of corridor through which a virus like Bundibugyo can move before surveillance systems catch it. This is not a failure of science or medicine. It is a failure of the underlying conditions in which science and medicine have to operate. For anyone watching this outside the affected regions, what does your actual risk look like right now? The CDC has assessed the risk to the general American public from the current DRC outbreak as low. The same assessment applies across most of Europe and other high-income countries. These viruses do not spread through casual contact, through air, or through food. They transmit through direct contact with the bodily fluids of a person who is already symptomatic: blood, vomit, sweat, other secretions. An infected person who is still in the incubation period, showing no symptoms, is not considered contagious. This is a meaningful distinction from airborne diseases, and it is one of the primary reasons that with appropriate infection control, healthcare workers can treat these patients safely. The people at elevated risk are healthcare workers in affected regions without adequate personal protective equipment, people who have had direct physical contact with a confirmed case, and people who have traveled to Ituri province in DRC or Kampala, Uganda, within the last 21 days, and who develop fever, muscle pain, weakness, or any unexplained bleeding. If that description applies to you or someone you know, the correct move is immediate contact with a physician, disclosure of the travel history, and isolation while testing is arranged. The 21-day window matters because that's the outer boundary of the incubation period for both diseases. What this outbreak does represent globally is a serious signal that the preparedness infrastructure the world built after COVID-19 is about to face a real-world test in real time. A Bundibugyo strain with no licensed vaccine, spreading in a conflict zone, with cross-border movement already confirmed. The PHEIC declaration was not an overreaction. It was the appropriate recognition that this will require coordinated international response, funding, personnel, equipment, logistics, at a level that no single country can provide on its own. The scientists and epidemiologists responding to this know what they're doing. The tools are better than they were in 2014, when West Africa's Ebola outbreak overwhelmed systems that weren't built for that scale. But better is not the same as sufficient, and that gap is what the next few weeks are going to reveal.